Assalamu alaikum. My name is Sayyada Mahanur Mohsin and my roll number is PP 1550184. My topic is thyroid disorders and my subtopic is hyperthyroidism with congestive heart failure. So basically what is thyroid? Thyroid is a small gland that is located in the front of the neck. You have thyroid glands throughout your body where they create and release substances that helps your body to do specific things. The thyroid makes hormones that helps control many vital organs of your body. There are two basic types of thyroid disorders: hyperthyroidism. If your body makes too much thyroid hormone, you can develop a condition called hyperthyroidism. And second, hypothyroidism. If your body makes too little thyroid hormone, it is called as hypothyroidism. So my focus is on hyperthyroidism. Hyperthyroidism is the condition of thyroid. The thyroid is a small butterfly-shaped gland located at the front of your neck. It produces tetraiodothyronine T4 and T3, which are two primary hormones that control how your cells use energy. The thyroid glands regulate the metabolism through the release of these hormones. Hyperthyroidism occurs when the thyroid makes too much of T4 and T3 or both. But what are the reasons of causes of hyperthyroidism? There are a variety of reasons that may cause hyperthyroidism. I have listed some of them here. Large amount of T4 taken through dietary supplements or medication, tumors of ovaries and testes, benign tumors of thyroid and pituitary glands, inflammation of thyroid which causes T4 and T3 to leak out of the gland, excess iodine are key ingredient in T4 and T3. There are a variety of conditions that may cause hyperthyroidism as well. For example, Graves' disease, an autoimmune disorder, it is a common cause of hypothyroidism. It causes antibodies to stimulate the thyroid to secrete too much hormone. Graves' disease occurs more often in women than in men, and it tends to run in family as it has genetic links. Now, what are the symptoms of hyperthyroidism? It basically shows hair loss, weight loss, breathing problems, enlarged thyroid, mood swings, hungers, and I've listed some here. Now, when it comes to treatment of hyperthyroidism, how can hyperthyroidism be treated? Here are some medications that should be used. Antithyroid medications such as methimazole stop the thyroid from making hormones. They are common treatment. Whereas radioactive iodine is given over 70% of US adults with hyperthyroidism, according to American Thyroid Association. Common side effects are also associated with radioactive iodine, which includes dry mouth, dry eyes, sore throat, and changes in taste. Precautions should be taken while taking radioactive iodines. Whereas there are surgeries for hyperthyroidism, you will have to take thyroid hormone supplements to prevent hyperthyroidism, which occurs when you have an unreactive thyroid that secretes too little hormone. So now, as my topic is hyperthyroidism with congestive heart failure, let's see what's the impact of hyperthyroidism on congestive heart failure. Thyroid dysfunction is a common clinical problem that has key role in regulating the cardiovascular system and may contribute to the clinical course of CAD, HF, and arrhythmic events. Cardiac medication can imbalance or impair thyroid function. These things have taken into account in the assessment and treatment of cardiovascular disease. Thyroid function tests are needed in patients receiving immunoglobulin and when thyroid dysfunction is considered a possible cause of heart failure. There is an interrelation between thyroid function and cardiovascular system, which should be taken under control if a patient is going through hyperthyroidism. My case for hyperthyroidism with congestive heart failure shows that SK, a 48-year-old woman, is admitted to the hospital for a possible MI. Her complaints include chest pain that is unrevealed by NTG, increasing SOB with exercise, nervousness, palpitation, muscle weakness, weight loss, increased appetite. She also has bruises easily. She has history of deep venous thrombosis treated with warfarin. Physical examination reveals thin, flushed, hyperkinetic nervous woman. Blood pressure is 180/90. There are other also symptoms defined here, whereas the laboratory data is also listed below. A scan shows a diffusely enlarged gland 3-4 times than the normal size. What subjective and objective data are suggestive of hyperthyroidism in SK? Basically, in this case, she has a history of deep venous thrombosis treated with warfarin, 5 mg per day. Her last thrombin time was 18 seconds and international normalized ratio was 1.8. She has angina treated with NTG 0.4 mg and CHF treated with digoxin. Whereas her complaints include chest pain, increasing SOB, with exercise nervousness, palpitation, muscle weakness, weight loss despite of an increased appetite. My assessment for this case is, as the symptoms shows, a diagnosis of Graves' disease is confirmed by an elevated T4 level and undetectable TSH level, increased RAIU, positive TPO antibodies, and a diffusely large filter. Her cardiac status and medical problems are aggravated by the hyperthyroidism. Management for this case is warfarin should be monitored carefully in patients with thyroid abnormalities, and the dose should be adjusted as the thyroid status changes. Because SK's hyperthyroidism will more likely to be treated with thioamide, so cautions must be exercised. Treatment of hyperthyroid patients with thioamide, especially PTU, has been associated with hypogrothambulimia and bleeding. Symptoms occurs 2 weeks to 8 months after the therapy started. SK should maintain on warfarin because of high prevalence of systemic embolization in thyrotoxic patients with AF. Anticoagulation should be started when the AF is first diagnosed and continued until SK is euthyroid. The risk versus benefits of anticoagulants should be weighted before therapies because an increased sensitivity of warfarin is observed. Close monitoring is warranted. So that's all for today. Thank you for your time. Jazakallah.